largest part of my abdomen and concentrate on those fetal movements.
Like around the back.
Yeah, because again, we don't want that compression of the vena cava. So again, lying on their side, or if they can on their stomach, but usually on their side is the best. All right, ultrasound. So we do fetal surveillance, looking at the baby, looking at the nuchal translucency. So again, looking at that fluid in the nape of the neck, looking for any abnormalities. Again, looking to identify if there's anything wrong anatomy-wise with the baby. We can see the baby moving around. You can see there's even the 3D and 4D now, which are more lifelike pictures, and you can see like a face outline and things like that. Amniocentesis, this is when they obtain a sample of the amniotic fluid. So they take a needle and insert it transabdominally to get the fluid. Again, they use the proper location with a guided ultrasound. So they look at this if they have concerns, maybe genetic concerns or fetal diseases. Less than 1% complication, which you would think it would be more, right? Because I don't know, when I imagine this, I think of like a pin in a water balloon and it's leaking the fluid, but it doesn't work that way. So, but yeah, less than 1%. Chorionic villus sampling, or CVS. Again, this is when they aspirate a piece of placental tissue for chromosomal or metabolic DNA testing. So there's about a 7% risk of fetal loss with this due to bleeding, infection, or rupture of membrane. So again, a little bit increased, but if they have a need to have this done, they have to wait, see if the benefits outweigh the risks. Maternal serum, alpha fetal protein, or MSAFP. Again, you can see when that is screened there. When we're looking at this, if that comes back high, we're thinking neurotube defects, okay? Anything that's low, we would think are trisomies. So trisomy 21 are Downs, or trisomy 18 are Edwards. So you get maternal blood drawn and send it to lab for analysis with this. Percutaneous umbilical blood sampling, or PUBS. We draw that blood right from that umbilical vein. And again, it's analyzed for chromosomal defects. It can also be called fetal blood sampling, or chordocentesis as well. It's performed after 18 weeks and ultrasound guided as well. And then again, make sure you're checking the baby post procedure. Coombs test, so it's important to understand Coombs. It's important for your test in here. It's important for the NCLEX. So understanding RH incompatibility. So RH incompatibility occurs when a mom has an RH negative. So think of like a negative bad mom, right? And so with that, if they give birth to an infant who is RH positive, it's positive to have a baby, right? Mixing of that maternal and fetal blood, either during the pregnancy or during the birth process, can cause mom's antibodies to attack the baby's red blood cells, adhering to them, lysing them. So again, as you can imagine, it can really damage the baby. So what we do is we screen for blood types, right? It's done at that first visit. We rescreen again in second trimester. If mom is an RH negative mom, at 28 weeks, they're going to administer the RhoGAM, and then they get RhoGAM again right after delivery. So again, looking at that. NST, so your non-stress test. We use this for fetal heart rate patterns and accelerations. It tells us fetal well-being. It tells us the baby's doing well, right? It's one of the most widely accepted methods of evaluating the fetus. It's reactive, and again, it's important to remember numbers. It's reactive when it's 15 beats above baseline for 15 seconds, 2 or more times in 20 minutes. So again, that's why you'll see the 15 times 15, you'll see it written that way sometimes. So 15 beats above baseline for 15 seconds, 2 or more times in 20 minutes. So that's considered a reactive NST, okay? It's non-reactive if they don't have accelerations within 40 minutes. So we'll try it and then retry it again. So if they fail this NST, then they have to go on and have a BPP, which we'll talk about the biophysical profile in the next two slides from now. So again, sometimes with the NST, the baby's sleepy, right? It could be in a quiet sleep state. So we can do things like give some orange juice for a sugar rush, or they have this like vibroacoustic stimulator that they can place against the belly to kind of wake up and see if that helps as well. Sometimes it could be from narcotic abuse, maternal smoking, or even fetal malformation. So again, if they don't pass it the first 20 minutes, they'll do another 20 minutes. If they still don't pass after 40 minutes, and they're moving on to the BPP. And this is just kind of what we see when we look at that NST, what it looks like.
You went backwards.
Oh, sorry. All right, BPP, biophysical profile. So again, when we look at this, if they fail that NST, they're gonna have a BPP done. So when you look at it, there's these different categories, just like when we do scoring. So you can see like fetal breathing movements, right? So normal 2 means that they have 1 or more episodes in 30 minutes lasting greater than 30 seconds. Or maybe they're absent breathing, right? So then they would get a 0. And so you'll go through and rate those 5 different categories. So the breathing, the gross body movements, fetal tone, fetal heart rate, and amniotic fluid volume. All right, so when they go through and add all that up, 8 out of 10, 10 out of 10, think of like what your APGAR scores are, right? Those are good scores. That means that it's considered normal. But anything less than that would require some interventions. Especially if it was like 2 out of 10, right? 2 out of 10 means they're coming to take that baby right now because there's probably something wrong with that. Biochemical screening, so they draw maternal blood. You can either do a triple screen or a quad screen. With a triple screen, you can see the 3 things that they test on the screen. With the quad, you can see the 4. Again, when they screen for these are what they say, screening tests, right? So when you think of this, it's going to screen. For example, in a triple screen, if all 3 of these are low, right, they're going to think it's Down syndrome. But that's not always the case. It's not always Downs, okay? Like I have a niece who came back, she was positive on the triple screen for Downs, and her baby's just Down syndrome. So again, thinking about that. All right, that's the end from last week. Now we'll move on